it's not just about what we're doing here and now in the human population, but also what's ongoing in the animal population. So it's something that we have to think about. And as we know, there's been no new antibiotics for 30 years. There's widespread use of antibiotics. And of course, we have travel, and we have health travel in particular, where people are travelling for cosmetic procedures, etc., and being exposed to healthcare systems elsewhere and bringing back resistant mechanisms to their own countries from some of the areas which have higher resistance populations. So we really need a One Health approach to all this. And I did some work a couple of years ago with some vets in Health Protection Scotland, looking at how we look at how antimicrobials are used within the animal sector. And they too are bought into reducing down inappropriate antimicrobial usage. And that slide's just to say that we had a significant amount of antimicrobials developed in the 60s, 70s, etc., but nothing particularly since. And it's true to say that we have limited areas that we know of on a bacterial cell that we can target, which hasn't already been targeted with one of the classes of antibiotics that we have. So we're suffering from a fatigue in how we manage bacterial, how we get on top of bacterial resistance, etc. And these graphs are these maps rather are quite interesting to look at. So the map on the left-hand side shows you that back in 2004, within Europe, the number of E. coli, or the percentage of E. coli isolates that were resistant to third-generation cephalosporins. And green, the more green a country is, the less resistance is there, and the more orange or yellow, orange, red, the more resistance. And you can see within that 6 years the significance of how that resistance has spread. And if we look at the most up-to-date slide, we're now looking at 2004 versus 2017, I think that is. And you can see that nowhere now is green. So in a 13-year period, there is very limited, there's nowhere that has less than 1% E. coli isolates, which are non-resistant to third-generation cephalosporins. So that's quite significant. And if we look at the next set of maps, this is particularly worrying, because this is the carbapenem resistance of Klebsiella pneumoniae. So again, going back to 2004 versus 2010, and it seems to be a slower increase in resistance, but an increase nonetheless. And if you look at places like Italy, and a lot of us have holidayed there, then you're seeing that something like between 5 to 20% of isolates are resistant to carbapenems. And here we come to 2017. And again, it's not as dramatic as the previous E. coli, but we are seeing a significant increase in resistance in something that is against our most broad spectrum antibiotics. So certainly something that we're concerned about. And if you think about why that happens, and this is data from 2016 from ECDC, so looking at antimicrobial consumption across certain countries. So we could see from those maps that Greece was a high incidence of resistance, and their total number, and it doesn't really matter what the number means, the total number of antibiotics used is sitting around 36 in primary care, and I think that's 2.5 or 2.39 or something in hospital. And if we move through to Italy, again high resistance. Again, you've got antibiotic use 26.9, 2.47 in the hospital sector. The UK, 19.57, so less use, less resistance is seen in the maps. And if we look at countries which have been looking, such as Sweden, which have been very engaged in antimicrobial stewardship and were doing significant amount of work way back in the early 2000s, they're sitting with a usage of 12 in terms of antibiotic use in secondary care and 1.65. And their antibiotic resistance is much lower. So if you need something to help you convince people that usage relates to resistance, then these are quite useful statements to look at, or it's quite useful data to look at. Within Scotland, where some of us are practicing, we can see that instead of going down our antimicrobial usage within the hospitals, there's been an 18% increase. So that concerns us somewhat, that we're not going in the right direction. And there's various reasons for that, but certainly it's something that we want to try and get a top on so that we don't keep going up exponentially in usage, because we know that that will be a driver for resistance. I think I might have missed a slide there. No. So if we think about where we are, so we've got a case here in Tuscany, 2010, so an old case now, 9 years ago. Patients admitted for a hip replacement, so you think, well, they're obviously not particularly unwell at the time of admission, or they wouldn't come in for an elective surgery. They were admitted post-op to a rehab unit with pneumonia. They were managed with broad-spectrum antibiotics, transferred to a district general hospital, received more broad-spectrum antibiotics, including cover for MRSA, and they didn't improve. And we're seeing this Klebsiella pneumoniae with a very resistant phenotype. They were then given colicin by IV and nebulized route, rifampicin, tigecycline, and meropenem. They improved, but unfortunately relapsed after 3 days. Relapsed after 3 days with a breakthrough bacteremia and septic shock and died. And this was their antibiogram at that time. And if that shows you how someone coming into hospital for a relatively simple operation, a relatively routine surgery, can end up succumbing because of resistance. So that's in a country that we know has a resistance issue. In the UK, and this goes back, I think, probably to around about 2012, 2010, was when we first started looking at the superbug NDM, so New Delhi metallolactamases. So the first of the sort of carbapenemases, and there was 50 cases in the UK so far when that was first hit the papers. I bring you now to the slide from NSS, so Scotland's only slide, which shows you the increase in carbapenemases producing organisms that's reported nationally. And you can see that year on year, we're seeing a huge increase. And okay, we're only seeing 100, 120 isolates, but if you move that to in a few years' time, then we're going to be seeing a significant number of these patients with this type of organism, which allows us very little in antimicrobial armoury to treat. So is it just resistance that concerns us? No, it's not. We have to think about other collateral damage. And if we think to those of us who were practicing or remember 2008 particularly well, in Scotland it's particularly poignant in terms of antimicrobial advocates was the veil of leaving when patients were dying of Clostridium difficile, and there was a public inquiry, and antimicrobial prescribing was cited as a contributory factor. So at that time, between 2009 2010, the focus nationally from government and from antimicrobial stalwarts was to get on top of our antimicrobial policies and to reduce down the risk factors for C. difficile. So what are the risk factors for C. difficile? What make the risk? Anyone give me some of the risk factors? So being immunosuppressed, that's correct. Antibiotics killing gut bacteria, broad spectrum, yep. Older age. Inpatient admission, yep, Rahul. Prolonged antibiotic use. So we have dehydration, gastric. Yes, I think you probably got most of the risk factors. So the broad spectrum antibiotics, and we classed those as the 4C antibiotics within Scotland. So clindamycin, coamoxiclav, ciprofloxacin, obviously quinolone, but cipro, and the cephalosporins. Whether or not you're on PPI therapy, so gastric acid suppression, being in hospital, having GI surgery or diseases which involve the colon, chemotherapy and immunosuppression from that. If you've had previous CDI, then you're more likely to succumb again, being older in age and having renal disease. So these are the things that we should be thinking about one of the things we should think about when we're choosing an antibiotic for our elderly population. It's around the C. diff risk. Looking at where we've come with CDIs, this is NHS England data from 2007 to 2008. So around that time of 7, 8 and 9, when we were looking at antibiotic usage within organisations and trusts and really cutting back on these kind of sort of C. diffigenic drugs, we did see a huge decrease in number of cases, and that was seen within Scotland as well. And it's kind of settled down to a kind of level, and I think we'll never be able to get rid of C. diff completely, but for me, I think that for every C. diff case, we should have had no other alternative in the antibiotics that we used if it is related to antibiotic therapy. And you do see C. diff cases that patients have no previous antibiotic exposure. But where antibiotic exposure is a factor, we should be able to say this is the only treatment option we could have given that patient when we were presented with the sepsis or the infection that they had, and therefore, unfortunately, it's resulted in C. diff, but that was the only option at the time. So I think that's where we need to get to with our antibiotic therapy when we review patients who have had C. diff. And this is a local picture from my own health board, and it's data from 2008 to 2014. And the pink line shows you how much ceftriaxone was being sent out by the pharmacy department to the hospital, and the blue line is the number of C. diff cases that were reported. And you can see it correlates quite well with a reduction in cephalosporin use, with a correlated reduction in C. diff rates. So it's all very well talking about stewardship, but what does it actually mean and what does it look like in clinical practice? We are very good at saying we need to reduce the overall burden, but that doesn't help the junior doctor at 5 in the morning or 3 in the morning when they have someone that they think's unwell and an infection is a likely cause of that. So how practical is it when you're saying only use where indicated? Same with a GP on a Friday afternoon with someone who's presenting unwell. Do you take the risk and not give an antibiotic? I think sampling is a big thing that we don't do enough of and we don't do well. Following empirical guidance. Using short courses, and definitely within Scotland, that's one of the things that they're going to be tackling. We're getting more evidence coming through around what is a long enough course to manage things like pneumonia, COPD exacerbations, etc. And can we get away with using shorter courses? Because if we think back, the amount of antibiotics we use drives resistance, so if we can reduce that down by shortening the course, then and still get clinical cure, then we'll reduce down exposure and resistance. Using narrow spectrum where possible, de-escalating, but you can't do that unless you have samples. IV to oral switch as soon as possible when patients are clinically stable. Use good infection control and removing external devices, so vent forms, catheters, etc. And a long course at too low a dose, Francis, does lead to resistance. So things like amoxicillin 250 milligrams, I don't think that's particularly helpful. I think we should be managing patients with doses that we know will cause effect. So I wouldn't say anyone that's an adult should be getting 250 milligrams of amoxicillin for any indication. So it's about using an adequate dose for as short a period of time as possible. Other stewardship measures are around audit. Are we using the right antibiotics? Are we using the right policies? Feeding back that information to the clinicians and to the primary prescribers. Antimicrobial ward rounds with antimicrobial pharmacists or infection control doctors, microbiology. Keeping an eye on how much antibiotics we're using, both within an organisation and practice level and up to health board level. And improved diagnostics, having bedside testing to allow us to be able to quantify the risk of infection in that patient and therefore be able to manage it. Is it something that will be self-limiting? Is it something that requires an antibiotic, and which antibiotic is the most appropriate? And keeping a very close eye on resistance patterns as time goes on. So looking to maximise therapy and minimise harm, we've chosen now to use an antibiotic in our patients. So how do we get the best benefit from that, and how do we reduce down the risk? What options do we have? So if we think about this lady, who is a 55-year-old lady with MS and an indwelling catheter, she presents with rigors, suprapubic tenderness and nausea and vomiting. She's parectal on admission, slightly hypotensive with a heart rate of 88. At the time when she was managed, the guidance in her organisation would have suggested amoxicillin, IV, and gentamicin, IV, as per protocol, or ciprofloxacin orally, depending on recent culture results. What is people's thoughts about this lady? What other information would you want, or would you want just to go with what the policy said? Yep, has she had recurrent UTIs? What's her kidney function? What else is wrong with her? Vital issue in sepsis. So what results would you want to see? Yeah, any resistance. So we think about this lady. She's an MS sufferer, so she's likely to have had recurrent urine infections. She's got an indwelling catheter. And if we look, her urine culture if we think this is recently, our most recent urine culture, I know it says 2014, I meant to change the date on that, sorry. But it was 2019. She's ESBL, and she's resistant to Cipro and gentamicin and amoxicillin. So there's no point in giving her what the guidance said, and only sensitive to tazocin. And our previous urine, again, was an ESBL E. coli, and it was resistant to tazocin, so only sensitive to amikacin and meropenem. So it's about looking at what the guidance says, but also how likely it is for that patient to not have risk factors for resistance, as well as all the other things around urine, renal function, and whether she can tolerate the antibiotics that you're suggesting for her. So in this case, you may wish to choose meropenem. So considerations of a suitable antibiotic. If we think about another gentleman, a 66-year-old man who has come in with, yes, definitely change a catheter. 66-year-old man admitted with a 2-day history of flu-like illness, followed by chills, sweating, vomiting, diarrhoea, increased confusion and incontinence. He's had a recent inpatient stay with sweats and fatigue. He's got a past medical history. He's diabetic, hypertensive, peripheral vascular disease, peptic ulcer disease, and he has renal calculi. 3 hospital admissions in the previous year, with several courses of antibiotics for recurrent UTIs and respiratory tract infections. He was colonised with MRSA on his last admission, and he was catheterised on his last admission. His examination and lab results show he's pyrexial. You can read the rest. Chest x-rays normal, creps in both bases, pansystolic murmur. His renal functions off, white cell counts raised, CRP's 302. In terms of antibiotics, what are you thinking? So we think he's got sepsis of unknown origin. It could be endocarditis, he could have a pyelonephritis, could be a hospital-acquired pneumonia or an upper UTI. What antibiotics would you be thinking of in this gentleman? What other information do you need? So we have some recent microbiology which is showing us about this MRSA colonisation. He grew Klebsiella in urine and blood during his last admission, and his urine had an Enterococcus faecalis 4 months ago. So what antibiotics would people be thinking? So vancomycin. Okay. So is vancomycin on its own sufficient in this gentleman? Okay. So I think it's safe to say that we need to have something that's going to cover the MRSA. So the vancomycin or linezolid, depending on the cultures, would be useful. But we'll also need something that's going to give us gram-negative cover to cover the Klebsiella, and looking at what the sensitivities on the previous admission were would certainly give us help. Metronidazole, not sure where that would sit with this, but I think adding it in wouldn't be a bad idea. But we want to have broad spectrum cover that's going to cover the vancomycin, the MRSA and the gram-negatives. So something like tazocin and vancomycin might be an answer, or vancomycin and gentamicin, depending on the Klebsiella sensitivities. So when we're managing infection, we need to think where the infection is, whether it's community acquired or healthcare associated, what the travel history of the patient is, what comorbidities they have, are they colonised, what recent samples, what allergy status they have, what their renal function's like, and a wee bit less so what their hepatic function's like. I think although it says about reducing doses and liver impairment with certain antibiotics, I think in general you just go with the dose that you know is going to work. But certainly for renal impairment, you would look at dose reducing, etc., if necessary. So PIP-TAZ with vancomycin will give you anaerobic cover, gram-positive and gram-negative cover, and hopefully that will have covered the previous sensitivities that we had. So I'd be relatively happy with that until we get back cultures. Whoops. So another example that we can have a wee think about, a 67-year-old lady who's 2 days post-total hip resection, white cell count's 12.2, and her maximum temperature has been 37.8. You're called to the ward as it's been noted that her pre-op urine has identified 100,000 colony-forming units of enterococcus. She has a history of recurrent UTIs, but denies any symptoms pre-op. She also has a urinary catheter in situ. The nurses are raising concern over the prosthetic joint becoming infected. What's your answer? What do you do next? So do you start amoxicillin gent? Do you start comoxiclav? Do you give a start dose of gentamicin? Do you look up the urinalysis to identify the white cell count? Sorry about this, folks. Do you not treat as an asymptomatic bacteriuria, or do you repeat the urine culture and treat if still positive? Now we're going too far the other day. Well. Oh, for goodness sake. Okay, so we've got a range of thoughts there. We are treat only if symptomatic. Some people are saying repeat. Some people are saying give comoxiclav. I think it's around, as Nadia is saying, you treat the patient, not the labs. So there's a high proportion of elderly people will have asymptomatic bacteriuria. And treating that will only create problems. She says she doesn't have any symptoms when she went to pre-op. So the urine sample that we've got from her is an asymptomatic bacteriuria. And therefore, I think in this patient, the most reasonable way to manage it is to not treat her, as it's an asymptomatic bacteriuria. You may want to keep a close eye on her, and she spikes a temperature, she's got a catheter in, etc. So she has got risk factors for developing a UTI. But at the moment, I don't think it warrants antimicrobial therapy. And unfortunately, sometimes you get into a case of chasing cultures. So you have a patient comes to pre-op, they hand a sample in, you treat it, they come back, they're now more resistant, you treat it again, and you end up that the patient never ends up going for theatre, never goes to theatre, because we're treating this asymptomatic bacteriuria, which we're causing more and more resistance in by giving antibiotics, when in fact, if you think about it, the surgical prophylaxis that you give to a patient will probably cover most of what's in the urine anyway at the time of induction. So I would say that the most appropriate management in this patient would be not to treat it. So we've kind of had a look at managing some of the infections, and then we have to think about how do we get what is the best drug for that patient? Where are we trying to get the antibiotic to? And we have to think about how well the antibiotic will penetrate into the tissue that's infected. And we know about the barriers that we have to diffusion with the brain, the prostate, into the bladder, etc. The physical chemical properties of the drug may make a difference. Sorry, could you come up with a setting of the patient was pre-op or post-op? Does it make a difference? I think the fact that they are asymptomatic and have a bacteriuria, whether they were pre-op or post-op, doesn't make a difference in this case. I think if they were post-op and they were symptomatic, then you would want to treat that. So if they were spiking a temperature, if they've got a catheter in, so urinary frequency, etc., wouldn't be an issue. But if they're feeling unwell and they had a temperature, then you would want to manage that with an antibiotic. But the fact that that was from a pre-op sample and they were asymptomatic at the time of getting the sample, then you wouldn't treat. We have to think about the physical chemical properties of a drug and whether or not the disease that we're managing is going to affect how that drug will penetrate into the areas. So inflamed meninges will help get drugs across the meningeal barrier. Sepsis, there's various things that go on in terms of what happens to the capillary leakage, etc., during sepsis, and where drugs will eventually end up. If protein binding, it's the free drug that's active, so changes in protein binding will affect how well a drug works. So looking at this in a wee bit more depth, we'll look at some of the tissue penetration thoughts that we can have, pharmacokinetic, pharmacodynamic parameters, and we'll come on to some Gent and Bank stuff at the end, and changes due to sepsis. So we use quinolones a lot in prostate therapy because it passes into the prostate better than trimethoprim. Trimethoprim still will get in and certainly can be used, particularly with all the concerns we have over quinolones and the MHRA warnings around safety and that have come out in the last year or so around quinolone use. But again, using trimethoprim, you may need to use longer courses. Gentamicin doesn't distribute well into bile bronchial secretions, so not very good in managing those into the sputum and into the CSF. Nitrofurantoin, and I don't think anyone needs to be told this, is not managed. We don't manage infections unless they're urinary tract infections because it only concentrates in the kidney. So we don't use it if you're systemically unwell. And clindamycin is very good at getting into bone and joint, soft tissue, but has minimal CNS distribution. So knowing these things can help us to decide which antibiotic we're going to use after we've decided about cover. Looking at how antibiotics work in terms of how they maximise their kill, we have different parameters. So for some drugs, we have the time that the antibiotic is above, or the time that the concentration is above the minimum inhibitory concentration is what maximises the kill. In other antibiotics, the peak that we receive in terms of serum concentration over the MIC is what gives us the best kill. And in other antibiotics, it's the area under the curve to the MIC ratio that allows us to maximise effect. So knowing those parameters, and we'll come on to this in the next slide, helps us to know how best to give an antibiotic in terms of frequency and dose. So for drugs where the Cmax, so the maximum concentration above MIC is the dominant way of causing cell death or bacterial cell death, allows us to give things as large and frequent dosing, which is why aminoglycosides are best managed through 24-hour regimes and not 3 times a day as they were traditionally. The time above the MIC dominant allows us to give frequent smaller doses, so things that are like penicillins 4 times a day, cephalosporins, unless they're the ones with a long half-life. So they allow us to give it more frequently, and where the total drug exposure, drugs such as glycopeptides and tetracyclines and fluoroquinolones, is where you're maximising the effect and exposure to the drug. And we have to think about how these parameters change in terms of physiochemical changes that come throughout disease. or caused by disease. So certainly sepsis will alter how our body handles medicines, and it will alter our volume of distribution. So antibiotics such as aminoglycosides, beta-lactams, glycopeptides, and colicin are mostly affected in critically ill patients because of that increased volume of distribution. You get leakage, capillary leakage, etc., which increases the volume of distribution, and altered drug clearance. So these drugs are ones that we need to be particularly careful about to make sure that we're getting the maximum benefit. So if someone's volume of distribution goes up, what does that do to the maximum tissue concentration? It decreases. Yep. So if you think C predicted equals dose over distribution. So if your volume of distribution goes up, your maximum dose in the serum or the tissue will decrease. The lipophilic antibiotics, such as the quinolones and the macrolides, they have less volume of distribution alterations because they're not water soluble, so less of an effect on those, but you may develop altered drug clearances because the renal function is still affected in sepsis. So getting an understanding of that, and that's where I think drug delivery will go in the future, where you maybe take more levels of patients' serums for different drugs and not just the aminoglycosides and the glycopeptides, will help us to maximise dosing therapy in patients, particularly those who are incredibly unwell with sepsis and renal dysfunction. But it's useful to think about that in your ITU patients who are very edematous. We need to get levels in those patients because we need to know what we're managing, because our population kinetics that we use to give us an idea of how drugs may be handled will not hold true in that patient setting. Thinking about pharmacokinetics in practice, and this is where it gets a bit tricky. Gentamicin and vancomycin, and for any of the junior doctors, this is the bane of their lives. Certainly with a lot of the changes in policies over the last 10 years, our usage of these agents has gone up significantly. And they're really good agents. We just need to manage them appropriately and respect them, because they do come with toxicity. So gentamicin has a low molecular weight, it's water soluble, so it doesn't go into body fat, and it's minimally distributed into tissue fluids, and it's distributed in the extracellular water. It accumulates in the kidney cortex and the inner ear, which is why you get the toxicities that we see with that, and it distributes well into ascitic, pericardial, peritoneal, pleural fluids, etc. It does cross the placenta, so we need to be careful when we're using it in pregnant people, but it doesn't get well and distribute well into the CSF or into the vitreous humour. Talking about volume of distribution, again, you will increase your volume of distribution in patients who are obese, who are ascitic. CF patients typically have higher volume of distributions, patients who are pregnant, and the edematous patient, and as we said before, your kind of ITU patient with low albumin and edema, and obviously decreased volume of distribution in dehydrated patients. So if we think back to that, the C predicted is the dose over the volume of distribution. In our elderly patients who may be dehydrated, then we may end up getting a higher tissue level from a dose because of that reduced volume of distribution. And this is the way I try to think about obesity patients and getting my head around gentamicin and vancomycin in these patients. So if you take, for example, a 140 kilogram obese patient who has an ideal body weight of 70 kilos, then they have 70 kilos of lean tissue and 70 kilos of adipose tissue. And the extracellular fluid in these two tissue types is not the same. And if we think about the drug going in and accumulating in the extracellular fluid, then the two volumes are not the same in these two different types of tissue. So we can't treat that patient in terms of weight as a 70 kilo patient and use that as their weight, because that won't give us the right dose, because we've still got 70 kilos of adipose tissue to treat. And we can't treat them as an 140 kilogram patient because the 70 kilos of adipose tissue has a smaller extracellular fluid volume than 70 kilos of lean tissue. Does that make sense? So we need to find a dosing weight somewhere in between. And that's why we have a kind of fiddle factor for patients who are obese in working out their dosing weight or their volume of distribution. And basically, if you're taking a weight of a patient and they're above their ideal body weight, then one of the equations that you can use is taking their total body weight and taking away from that the ideal body weight, multiplying that by 0.4 and adding that to the ideal body weight will give you a dosing weight which should be suitable or more suitable for working out their gentamicin dose. For those of you in the UK, there's lots of gentamicin calculators which will do that, and for those of you that are lucky enough to work in Scotland, then the SAPG, the Scottish Antimicrobial Prescribing Group calculator, will do that for you and will give you a dosing weight if you put in their height, weight and creatinine clearance. They'll work out the dose of gentamicin that you should use. And those of you who work in other countries, do you have calculators to work out gentamicin levels? Online programs, not in Nambia. In your country, how does it work? Clinical pharmacists, aye. And certainly, I think we can share the antibiotic, the calculators, because they're available on the internet. And I'm happy to share the one that we use in Scotland because it's available through the SAPG website, which you could use in other countries, because the only thing that you may struggle with is if your creatinine is not measured in micromoles per litre. but it may be something that you could use, and I can pick this up with Francis tomorrow about getting the link for that. So sticking with gentamicin, it has first order kinetics. Thank you, Francis, that's brilliant. Sticking with gentamicin, it's first order kinetics. So after a dose, there's an exponential decay. So the kidneys are continuously removing the drug. And obviously, if the patient's renal function is compromised, then excretion is less efficient. And we should consider that before commencing the course. And the half-life is about an hour and a half to 2 hours, although in someone who's renally impaired, it can go up to 30 hours. So we should only be using gentamicin in patients if they have severe renal impairment, if there's no other options. Again, in pregnancy, and it's absolutely contraindicated in myasthenia gravis. We know about the side effects of gentamicin. We have cochlear and vestibular apparatus which is affected, leading to either a vestibular toxicity which isn't reversible, or we can have auditory damage, which again is not reversible in all cases. So we should be looking for these toxicities. And I must admit, gentamicin scares me more than vancomycin. I see more toxicity with gentamicin than I do with vanc. The renal toxicity, depending on which textbook or paper you read, can be up to 1 in 4 patients will experience in that, but it's usually reversible, and if we monitor levels and make sure that we don't keep dosing, which is the issue that we see when this goes wrong, is that patients don't have levels checked and someone gives another dose. That's when we run the risk of more toxicity, or if we're using it with other ototoxic things like diuretics. Tends to come on gradually. Urine output declines, and time of onset is within 2 to 7 days of starting treatment. You then see a proteinuria and a progressive rise in serum creatinine. So it's about monitoring the patient, monitoring the urine output, particularly in elderly patients, and making sure that you're doing levels and you're checking U's and E's. Except in some countries that it's not it's not always possible to get drug levels done frequently and urine or U's and E's done frequently. However, it is something that monitoring urine output is a way of trying to counteract that if you're limited with what other mechanisms you can use to monitor. We use extended interval dosing, going back to what we were thinking about in the pharmacokinetics, pharmacodynamics parameters, maximising that, because that's what maximises bacterial kill and minimises toxicity. We do have post-antibiotic effect with gentamicin, which unfortunately, if you keep giving the dose, because the bugs are stunned when you give a dose of gentamicin for a period of time, if you keep giving the drug in that interval, you'll just give toxicity issues and you won't actually do any more in terms of kill. So knowing about that and maximising the once daily type dosing gives us the best outcome for gentamicin, which is a change over the past 15, 20 years when it was traditionally TDS dosing. As I say, vancomycin doesn't particularly concern me as much as gentamicin. What tends to happen with vancomycin is we don't give enough. So it's a different antibiotic, large molecular weight, doesn't penetrate most body spaces well. Lung penetration is variable, so not always an ideal treatment for pneumonias. Again, renally excreted with a much longer half-life. If you give it very quickly, you'll get a histamine release, leading to red man syndrome. It is cautioned in renal impairment, and it can cause renal impairment, Ototoxicity is also an issue. What I see more is neutropenia with prolonged use or high dosage. I've seen that in several patients. Dosing regimes. The big thing about vancomycin is a loading dose. It's really important that we give a loading dose. If you think about the half-life of 11 hours, 5 half-lives to steady state, so 55 hours before you're actually getting the patient at steady state. So we need to load to get rid of that. We give a loading dose based on actual body weight, and then we give a maintenance dose, again based on a maximum body weight. So what we discussed earlier for gentamicin, and the calculators will do that for you. Again, obesity is an issue. Like a larger volume of distribution, increased clearance due to increased cardiac output. So the effect that you can have, though, with vancomycin and obesity is not as clear-cut. So we use the calculator if we have one to get a dose and then target levels. I'm sorry I'm running over a wee bit. So this ideal pharmacokinetic profile, the red line shows you what you're looking for, which is giving the loading dose, getting up to a decent concentration, and then keeping the dose going. So whereas traditionally, if you were giving in intervals, it would take you 5 half-lives to get up to that steady state level. So you really need to get it up there and keep it up there is how vancomycin best works, because this is a drug that's the maximum concentration over time is what we're looking for, and not the time above the MIC. It's the concentration above the MIC is the parameter we're looking for with this. So I think this is the last case example of the day. Whoops, having awful bother with this slide movement. So we've got a patient, male patient, who's again a hip replacement, presents with pain 15 days post-op with a red wound, which is oozing, high temperature, BP's a little on the low side, systolic, heart rate's up a wee bit, white cell and CRP's up, previously had MRSA, so commenced on vancomycin. Day 3, his temperature's still up. Day 4, it's still up and getting worse, CRP's rising. Day 5, his temperature's not settling, BP's getting worse, and his CRP's going up. What are the possible explanations? Over to you. Okay. Okay, so we've got a thought around, is it getting into the bone? So if we give enough, it does. Is it the right antibiotic? Is it anaerobic and gram-negative? Is the vancomycin, is it a resistant organism? So is it a VRE? Is the dosing correct? Okay. So it is the correct antibiotic, so it's not a gram-negative. We've cultured and we know it is an MRSA. Is it the correct dose? So, day 2, the vancomycin level's 9. So in this patient, really we'd be looking for a level of 15 to 20 milligrams per litre. So we've got a level of 9 at day 2. Day 3, we haven't done anything, and we've not got a level, we've not increased the dose. Day 4 rather, it's sitting at 11. So this is an excellent example where we've got the patient in 5 days and we've not given the right dose. And this happens all too often. It happens in my own hospital all too often. And sometimes with vancomycin, in young, kind of fit guys who've got high urine, kidney, renal function or high sort of creatinine clearances, sometimes you just cannot get enough vancomycin into them to give you decent levels, and we have to go to something else. You either switch to linezolid or you go to daptomycin. But it's about measuring the levels to make sure that we're actually getting what is a decent amount of exposure. So loading dose for vancomycin, checking levels and acting on them. Deep-seated infections, 20 milligrams per litre. Monitor renal function, and this is the same with gentamicin. Often patients come into hospital and their renal function's poor because they're dehydrated, they're septic. But as their renal function improves, we don't often go back and recalculate drugs such as Gent and Vanc that we've actually initially calculated based on their initial renal function. So if the renal function dramatically improves, we need to think about changing or reviewing what dose of antibiotics they're getting. So we need to think about all the calculators in the world are based on population kinetics, which is not individual patients. So we need to look at the levels that you're getting in that individual patient and maximise therapy with that. And we need to know when the level was taken in relation to the time of administration to be able to do something with it. There's no point in knowing someone's got a level of 6 if we don't know when the drug was last given. So that's something that we can try and improve with nursing staff, etc. So what does the future hold? We don't know because the slide won't move. Well, we know there's not many, if any, antibiotics in the pipeline. We have to think about dusting down some of the older antibiotics. For example, colicin, and we use that. I don't use it very often in our hospital. We use it nebulized in bronchiectasis and CF patients. But actually, IV treatment, it causes significant renal toxicity, and it's a concern from that point of view. Tigecycline, mortality was increased in some of the trials with tigecycline, so it's not ideal, and we use it if there's no alternatives. Amikacin, again, it's an aminoglycoside, so there's issues with narrow therapeutic index there. There was supply issues with amikacin recently. Pivmecillinam, which is very good for ESBLs. It's an oral antibiotic. It's not available in IV. Temacillin, giving high-dose temacillin is good for ESBLs. Fossamycin is licensed in the UK now and it is available IV, but again wouldn't be used on its own because it doesn't give you enough cover and it doesn't give you enough. It's not a drug that we would use on its own. We'd want to give it with other antibiotics. So there's not a huge amount out there to support ongoing resistance. So it's about preserving the armoury that we have and managing things judiciously and trying to do the best we can. So that's been a very quick run through of antimicrobial stewardship and antimicrobial drug therapy. And any questions? So you want 5th generation cephalosporins are coming on board.